For joining. I'm Ashley Sutphin, she, her, hers from City Match, and I'm here as technical support and the host of the webinar. So if you have any technical difficulties or issues, please feel free to directly message me. I'll be keeping eyes on participant list and the chat for our presentation today. So again, just a couple housekeepings items. As we've been in the world of webinars, we know to keep our audio muted during the presentations, but there will be time for Q&A and questions, and we encourage you to come off mute during that time. Utilize the chat, as I will be watching that and elevating those to our speakers and presenters today. So thank you for being here. This webinar is being recorded, so please do know that. And we will be posting it afterwards for archive, and CEU's information will be provided as well. And Bill, I will hand it over to you.
Great, thanks so much. Welcome everyone to today's webinar. We're going to talk about safety surveillance through the Antiretroviral Pregnancy Registry. I'll turn to the next slide just so you can see the presenters, and I'll introduce myself last. So for those of you who have joined us before, I can't remember how many years we've been doing this, but this is an annual event, but it's been at least maybe 5, 6, 7, 8 years, probably longer. But you know, we really come before you to talk about the importance, and hopefully you'll walk away with that importance of why you need to report to the registry, or should report to the registry. So Dr. Lynn Moffison, Dr. Angela Shirley, and myself have been doing this for the entire time. We have someone new and we're very excited about, who has also joined the Antiretroviral Pregnancy Registry as an advisor, Angelina Namiba. So we're very excited to have her on board. And I don't want to do very long introductions because each person has a section, and I'd rather you hear their content and get to meet them when we go there. Disclosures are listed here on the slide. And really today, the objectives are to walk away after you hear the lecture and describe what are the objectives of the Antiretroviral Pregnancy Registry, list some of the key findings from the data, list 4 steps on how to report a drug exposure to the APR, identify early warning signals of major teratogeny, and I might add at the end, really realize the importance, as I said, of reporting to the registry, and really maybe walk away with a sense that this is something you'd like to do. All right, so I'm going to start with a case study, as I always do. And this is someone directly from the clinic. So it's a 32-year-old cisgender female who was referred to perinatal clinic. She was diagnosed with HIV in December of 2020, and she started on co-formulated bictegravir FTC TAF, as most people do in clinics. Her latest CD4 count is 450, and her viral load is fully suppressed at less than 20 copies. She's now 16 weeks pregnant, and I think important to note that most people don't present right after they have a missed menstrual cycle. They present somewhere around this, and I've seen people present much later. And so the questions that get asked are, you know, is this drug safe to be used during pregnancy by provider as well as the patient? And then I often get asked this constantly, should this regimen be switched? So I think before we even move forward, first thing is these questions should really be asked before you start someone on a medication, right? That's the first thing. But here we are. We have a person who's 16 weeks pregnant, and so we have to figure out best and next steps to, how to do it. And hopefully you'll get that through this webinar. So why are we talking about pregnancy and HIV? So we know really that there have been major improvements in health and life expectancy, really dating back to 1996 when combination antiretroviral therapy was approved. And so as a result of that and decreased morbidity, mortality, many people living with HIV desire childbearing. This number has been updated, but in the US, there are approximately 3,300 women living with HIV who give birth annually. And the problem is the guidelines for non-pregnant individuals recommend treatment for all. However, people tend to enter pregnancy already on ART, and there is a delay between the adult and adolescent guidelines when drugs are approved and pregnancy guidelines. And I'm going to show you why later on in the course, why that happens. And Lynn Moffison will take us through a series of the newer drugs and show why we have these large gaps. So we know that pregnant people are often not included in pre-licensure studies of new drugs unless the drug is being studied for a pregnancy-related indication. So very few drugs receive an FDA indication approval with pregnancy data at hand. So we know that one source of data for teratogeny is animal studies, but we know the predictive value is not always known. And you'll see through some of the things we talked about with certain drugs, that it was not always predictive of what was going to happen. And as I said, because of this, we wind up coming out with a really a paucity of data when drugs are FDA approved. So then really, what about drug therapy in pregnancy? It really is a balancing act, right? You really have to look at what are the benefits of maternal treatment. Well, we know that, it's suppressing viral load, improve morbidity, mortality, and, hopefully eliminating a perinatal transmission, which none of us want. But then you have to balance it out with the risk of adverse fetal effects. And so, as I mentioned earlier, you have this sort of balancing act, but there are often minimal data to make these recommendations. So, and as you saw in our case, some people aren't even having the conversations, and you have someone who's coming and sitting in front of you, 16 weeks pregnant on a medication, and your question is it safe? So I think it's important to keep this in mind, and this is courtesy of Lynn Moffisan, who I think it's wonderful. If you remember back, this is in the classic embryology textbook, but it really is important, especially if you're, the first comment that came to your mind when we talked about co-formulated bictegravir was switch the patient off the medication if that was your recommendation. I'm going to show you that where things happen, probably 16 weeks is not the right time to do it. So this is looking over periods of fetal development, starting with the dividing zygote, implementation embryo, going into the embryonic period, and then the fetal period, and then you see full term. And what you notice at the top there, when you look at where all the organogenesis occurs, it's largely within the first 8 weeks, and you'll see that some of it's very early on. So, and you look at the degree of sensitivity when you worry about teratogenic things, and they really tend to occur early on. And over time, when you start getting into fetal period, they go down. They don't go away, but they go down. And then I really like this graph at the bottom where you see the greatest sensitivity. And let's just look at our case for a second. We're all the way out here to 16 weeks. I don't know if you can see my pointer. Obviously here, everything is blue, less sensitive. It's not zero, but it's less sensitive, right? All that occurred out here. So to switch someone, and I think a takeaway point for me is, and when I use this in teaching, is really consider where you're switching. What are you really doing? And you run the risk of, the patient in front of you not tolerating the drug, nauseated, you have hormonal changes, not taking the medication, virologic rebound, and potentially a transmission. All right, so I showed you the risk. So here we are, weeks 3 to 8. This is the period of embryogenesis. This is a major organ development. This is the most sensitive period. And again, most of the people that I see presenting to clinic have not presented in this time period. Most of them are much later and after that. And I think one of the big things, and when Lynn Moffisan talks about the neural tube defect signal that was seen with dolutegravir, that's a very early signal. So neural tube closes by 28 weeks post-conception. That's 6 weeks after your last menstrual period. So again, very early events. And then again, here's your fetal period in weeks. And again, you can see what happens there. You have some fetal growth, teeth, external genitalia, and your brain continues to develop. And here you start seeing things like alcohol after week 24 and fetal alcohol syndrome, and then smoking and IUGR. All right, so what data are needed that we need to make recommendations to have a regimen preferred? And so here's what we need. So we need 3 things: efficacy data, pharmacokinetic data, and safety. So efficacy data we usually have. It usually comes from non-pregnant individuals. So if you have a drug, let's just say dolutegravir, we have phase 3 clinical trials. We know it's efficacious. So we use that data for efficacy. Pharmacokinetic data is specific in pregnancy because drug levels, especially second and third trimester, tend to go down due to all the physiologic changes and changes in cytochromes and enzymes. So there's a lot of things that go on, volume and distribution. So your levels may decrease, and you worry there that with pregnancy, you may have lower levels. And so before any drug becomes preferred, you must have pharmacokinetic data. And then also safety. We have to evaluate birth defects and what happens to, maternal hypertension, preterm birth. So all these things need to be factored in, and you'll see that this often takes a long period of time. So this was a study published by Angela Kolbers a while ago, and this looked at the time from FDA drug approval to first published pharmacokinetic data in pregnancy. And here what you see are time 0 all the way out. And the bottom line here was there was a mean knowledge gap of about 6 years. So a drug is approved, And again, just like our patient here, patient comes in pregnant, we don't know anything about the pharmacokinetic levels, and so we left with this knowledge gap. The other thing we need to know is the relationship between the prevalence and the observed events. So in the pregnancy registry, we use the number of 200. So 200 exposures are needed to be able to detect a twofold increase in overall birth defects. And that's a prevalence of 300. It's like any other clinical trial or thing, right? You need to work with your statisticians. You need to do planning. You need to do sample size, power calculations. That's what all this is. So we need 200. So a lot of times when you're looking at, and I think we're going to show it to you, when you look at drugs like cabotegravir, you'll say, well, that's not included in your analysis. Why? Well, you're going to see why. It's because we don't have 200 first trimester exposures there yet. And so that's what that is. If you start looking at rare defects like neural tube, what you see is you need 2,000 exposures to detect a threefold. So very, very high number. And that's where problems come in that I'm not going to steal Lynn's thunder when she covers. So I decided to take a look to see, well, we know about PK. What about safety data? When have we seen that first 200 exposures? So we looked and we found very similar things. It was a median knowledge gap of 6 years. So now we're saying, so drug gets FDA approved, you have 6 years from the time you get pharmacokinetic data and safety data. That's a long period of time when drugs are being used, especially a drug like formulated bictegravir. We know bictegravir FTC TAF is a single tablet regimen, very commonly used, but we had minimal safety data, and that has finally changed because this drug was FDA approved in 2018. This is just looking down. We update this every time. Looking at the 200 first trimester exposures in the APR, dolutegravir was approved in 13, and it took 6 years to get that 200. You go down each single one. Bictegravir, we finally got in 22, so it was a little lower, 4 years. But look at CAB. It was approved in 2021, only 33 first trimester exposure as of July 2024. So now we're more than 3 years to date. So we'll see how long it takes for this. And this, I think we may have a little longer in the APR, but we'll see what happens over time. Just want to turn to a little bit of brief history on the APR. I won't spend a lot of time on this. So the APR was started in 1989. It started, and you can see up there at the top of the report, as the zendavidine registry. So zendavidine was approved, and we had people on this line who were involved in those very pivotal studies, the 076 study that really, from the time of reporting of those results, just really a stream of what happened afterwards to becoming recommended as treatment during pregnancy. It's got an FDA indication, new guidelines were developed. And then, so this registry was formed. It was a prospective international exposure registration study, and it was sponsored by both antiretroviral manufacturers as well as an advisory committee. This is a voluntary registration of prenatal exposures by treating healthcare providers. And I'm going to say this once, and we'll say it throughout the thing. Healthcare providers, there is a misconception that only physicians can report. That myth needs to be crossed out, erased out of everyone's head. It's any provider can report. It is not specifically physicians. So this APR is overseen by an advisory committee representing the CDC, NIH, FDA, and very other specialists. And all of us on the call running the webinar, we are all part of the Antiretroviral Pregnancy Registry. This was a part of the objectives. It provides early warning signals. So when we reach that 200, we're looking at overall birth defects. And the estimate the risk of major birth defects and compare it to the general population. When I show you the results, we'll show you that. And this really helps to supplement animal toxicology, clinical, and then epidemiologic studies. Because again, remember, not all studies from animal translate into humans. I think hearing this so far, I don't need to tell you the significant. It's really a unique project that's established to evaluate prenatal exposure to ARVs. It's designed to help not only clinicians, but patients as well weigh in the benefits and risks of treatment. And I can't emphasize enough that this is available. It's updated twice a year. It really should be used when you're having discussions. You can pull it up on the web, which we'll show you later. You can print out the report. You can print out the graphs. I mean, there's so many ways you could use this. I'm just going to run through this quickly. Here's a list of all the collaborative sponsors. You can see there are many. And the study design, as I mentioned earlier, was prospective exposure registration cohort study. And then again, healthcare providers, what you do, you will register pregnant persons that are exposed to ARV, report the ARV exposure throughout the pregnancy, and then provide an outcome. We'll talk a little bit when I show you the study design is that, and it should be coming next. This 1 and 2 bullet is where we differentiate prospective enrollment versus, and I'm so sorry, 1, 2, and 3. And I'll go through the next slide. But basically, you want prospective enrollments. That's what is counted in the primary analysis. You can always report all your data, but what we include when we report the analysis out is always the prospective data. And so here's the analytic method. So there's 3 ways reports come in. There's a prospective way, and that's, as I told you, you will register the patient before the outcome. And that's just to ensure that you register and you're not just reporting your good findings. We have a tendency to do that with publication bias. We only want to publish and put out there things that are positive, which in this case would be no birth defects, but we really want all exposures. So if you do that, the primary analysis is done by looking at the prevalence. So that's a number of defects over live birth. And what you see here is they compare it to 2 population comparators. It's the Metropolitan Atlanta Congenital Defects Program, and then the Texas Birth Defect Registry. And you can see the prevalence there. And then they also compare first trimester versus second and third. So that's one way. The other way that comes in is retrospective. So if you missed a primary way we do by sending in prospective reports, we're also happy to look at retrospective. All those are reviewed. And then finally, clinical studies come in, and they're done all through a secondary analysis. There are some that gets a little tricky that are included in prospective, but really we'll take all reports, but really what is needed and wanted to really move that needle and decrease the time is prospective reporting. So let's look at the clinical review procedures for the APR. So you submit the report to the
I think that's
APR.
Angela, Bill.
Oh, I'm so sorry. I didn't see her pictures removed. I am so sorry. Angela, I was going to just keep going. All right, so I'm going to turn it over to Angela now.
Yeah, I think my picture's on the previous slide.
Oh, that's why. Sorry.
Okay. So good morning. I'm Dr. Shirley. I'm at UT Southwestern. I'm a clinical geneticist, and I'm the clinical reviewer for APR. So the process of clinical review is a case is submitted to the APR. Those cases that have infant or fetal complications are then processed and forwarded to me. I look at what is available to me and am asked to answer a specific set of questions. Are there major and conditional malformations? I'll go over those definitions in a minute. Whether the case definition for an APR defect case is met, the possible temporal association between the embryogenesis of the defect and the exposure to the medication, whether there are any confounding factors, and whether there just simply isn't enough information for decisions in the above bullet points to be made. I then do a re-review with updated information if it becomes available. What happens after that is that every 6 months, a small working group will review all the cases, and then further discussion is done at the semi-annual meetings with everybody, with all the advisors and all the sponsors. Next slide, please. I don't think, there we go. So the concept of clinical assessment is that is the period of medication exposure such that it coincides with or might influence the embryogenesis of the affected organ. And the diagram that you saw earlier is very useful. There are influencing factors, some of which we know and some of which we don't. The persistence or half-life of the medication, we can pretty much guess. The other ones are up in the air. What is the mom's metabolism? What's the PK in this particular woman? What's the placental transfer of the medication? And then how much does the fetal metabolism actually matter to this? So there's this triangle, in my term, the teratogenicity triangle, that is going to play into whether there's an association in a causation between the medication and the defect. But I'm not doing causation. I'm doing temporal association. It's does the timing of the medication exposure make any sense with regard to the embryology? Next slide, please. Here's kind of what you get. So the black line in the middle is the pregnancy. This is not to scale. The embryogenesis of the defect is largely going to be first trimester. There are a few things that are later, second and third trimester things, but the vast majority of organogenesis takes place in the first trimester. If the medication exposure is clearly after the embryogenesis of the defect, there's no temporal association. Example, the child is born with a cleft lip. The medication exposure was only in the third trimester. The cleft lip, the embryogenesis of that is going to be by week 8 of post-conception. So obviously an exposure 2 trimesters later isn't going to matter. The thing is, pretty much any other exposure is going to matter in terms of saying, yes, there's a temporal association. Certainly if there's exposure throughout the pregnancy, if there's exposure that starts right about conception and keeps going on, something that starts preconceptionally but then doesn't stop until after the defect is formed. And then if there's a start-stop during pregnancy, if it overlaps that embryogenesis period, again, temporal association cannot be ruled out. Again, this isn't causation. It's just timing, basically. It's chronology. Next slide. I refer to it as applied embryology. So what do we need? What pieces of information are necessary to do this? We need some sort of dating of the pregnancy and timing of the medication exposure start and stop. Now, there are various ways to do that. There can be actual dates. Last menstrual period was on this date, medication was this date to this date, and delivery was this date. That's fine. There can be a general narrative, was on medication through conception and continued through delivery. Medication was confirmed throughout pregnancy, or you can do it relative to gestational age. Delivered at 35 weeks and was on medication for 12 weeks prior to that, or was on medication from 14 weeks through delivery. The wording that is available is less important than the precision of what that wording says. I need to be able to compare timing in the pregnancy with timing of medication exposure. Next slide, please. So when do you report? What do you report? Birth defects, the term, and as defined by both the CDC and Texas, are typically structural anomalies. They're not functional anomalies. So missing kidney, but not renal failure. Hydrocephalus, but not seizures. There are syndrome diagnoses that can be either categories, neural tube defect, skeletal dysplasia, ectodermal dysplasia, things like that, the various eponyms, Down syndrome, Williams syndrome, and then some specific conditions if those are known. And with the increase in genetic testing that's being done both prenatally and in the immediate postpartum period, we are getting a few more of these where we're actually able to pin down this child has this specific genetic condition. And then any supporting labs, cytogenetics, cell-free DNA is helpful, although that's recognized as a screening test. Specific DNA testing, and then specific knowledge about teratogenic infections. And in general, you see my footnote, over-reporting is the better default. If you don't know whether something should be included, just go ahead and include it. Next slide. Let's talk about major and minor conditional defect. The FDA and the European Medication Agency care about major and minor defects. This is how pharma has to report the SAEs to those agencies. The CDC in Texas care about public health importance, and this is subtly different. So the comparator groups collect and analyze defect data in a way that's different than what the FDA and the EMA actually want. So they don't talk about major and minor malformations. They talk about codable defects, stuff that's always collected if it's charted, and conditional defects, which are collected only under some circumstances. And they're not the same thing. They're mostly the same thing. Major defects are mostly codable and minor defects are mostly conditional. But you can see my somewhat complicated Venn diagram where it's not completely true that all codable defects are major and all minor defects are conditional. Next slide. So the categories that get assigned are defect, capital D, defect. This is a malformation that is always collected by both systems, holoprosencephaly, missing extremity, things like that, stuff that is unambiguous and always collected. Things that are not a major defect translates to conditional, which is a defect which is collected by MACDP or Texas only in the presence of a major defect. So there's a missing limb and there's a birthmark. Well, the birthmark by itself probably wouldn't be collected, but since there is the presence of a major malformation, we're going to add the birthmark in. If it's not a defect, it's something that is actively excluded by the CDC, by MACDP. And there's a list. They actually have a list of things that are actively excluded. And most of these are conditions that are related to prematurity, that are secondary to infection, or that are developmental abnormalities like autism. And things that are not a defect, but maybe something else, and this is a relatively short list that we've come across over time. Well, it's not a defect, but it's not actively excluded, and maybe it's something we need to keep in mind. Remembering that the APR is very conservative, and we're going to err on the side of including a case rather than excluding a case. Next slide. And I think that's me. So we go from one Angela to the other.
Thank you very much, Angela. So I'm just going to dive straight in. So my section, my 15 minutes, I'm going to talk about meaningfully engaging communities at the heart of the APR. I'm going to talk a bit about my background, my diagnosis, and accessing the earlier pregnancy interventions. And I'll talk about a bit about my interest in HIV and pregnancy research, why from a patient perspective, I feel that the APR is really important, but also how the APR involves us, why and how they involve us, and then I'll end with my experience so far. So in terms of my diagnosis, I was diagnosed 30 years ago at a time where we didn't really have the fantastic treatments that we have now, and where doctors were really just providing palliative care. But prior to my diagnosis, I'd always had dreams as a young woman. I always wanted to, learn how to drive. I wanted to get a degree from university. I wanted to have a 2-bedroom house with nice rugs and lots of plants. But I also wanted to have 4 children, 4 girls. I didn't plan for a partner or anything, but I just knew that I wanted to have 4 girls. And so on my diagnosis, I thought that my dream had kind of ended. But years later, having access to peer support and meeting other women living with HIV who had babies after diagnosis, I was able to have my daughter 5 years after my diagnosis. By then, we had a treatment in place. And I was one of those women who accessed the earliest, single treatment, the zidovudine. And the guidelines then were, we had treatment during pregnancy, we didn't breastfeed, and we had a cesarean section. But we know that HIV has changed now, and the management of HIV in pregnancy, including delivery and infant feeding options, have now changed. And we see more and more women choosing to breastfeed and being supported to do that, particularly beyond the WHO guideline countries. And a critical part of an integral part of these positive developments is the fact that, of course, we're able to access treatment, ARVs. And so treatment for ARV from diagnosis during pregnancy and during the breastfeeding period is crucial. However, 2 questions that moms-to-be, potential moms-to-be, and parents living with HIV and their partners have been asking and continue to ask even today are, firstly, what is this medication going to do to my unborn baby? Secondly, what impact is this medication going to have on my child in the long term, in the short term, and in the long term? And so I guess my personal experience of going through pregnancy, as well as that of working with and supporting women living with HIV over the years, led to me having a keen interest in the management of pregnant women living with HIV. And as such, my special area of interest has been and remains around HIV and pregnancy. And this was further strengthened in the year 2010 when, whilst working at an organization called Positively Women, which is now called Positively UK, we set up a pilot project called From Pregnancy to Baby and Beyond. This project was aimed at developing and delivering something called the Pregnancy Journey Whilst Living with HIV workshops, which were training for both pregnant women and those considering pregnancy after an HIV diagnosis. The project was in response to the then lack and gap in specific practical services that were geared towards supporting those going through the pregnancy journey whilst living with HIV. And years later, that project gave back to the Forum Network of Mental Mothers Living with HIV, which is a project that I work with now. And this is a perinatal peer mentoring project working with mentor mothers where we train, support, and skill them up to support their peers going through the pregnancy journey and also for their own personal development. The organization is led by 3 African migrant women, and all the work and projects are informed by network members. And we now do training, information webinars, and work with researchers, amongst many other things. And so I guess my interest in treatment and research literacy and the very much the passion for meaningful involvement of women living with HIV in all parts of the research cycle started about, I would say maybe 14, 15 years ago. This is when I trained as a treatment advocate with an organization called HIV iBase. This training opened up my eyes, I guess I could say that, and enabled me to not only have an understanding of the different aspects of ARVs, but it also made me realize that there was and still is a dearth of and a gap in the involvement of women in clinical trials, both as participants, but also as part of study teams. And so here I just want to draw your attention to a paper that a group of us women living with HIV and HIV clinicians wrote titled From Presumptive Exclusion Towards Fair Inclusion, Perspectives of the Involvement of Women Living with HIV in Clinical Trials, including stakeholders' view. This paper was published by SAGE on the 1st of February, 2022. So moving on, why do I think the APR is important from a patient perspective? Well, it's because it speaks to all of the above that all I've talked about. But because I also feel that it is critical that both women and parents living with HIV, researchers and pharma, we need all the answers that the APR provides through the incredibly important work you've done over the years and continue to do. But I also feel it's important because it puts us communities at the heart of the work that you do, that we do now. As a member of the advisory committee, I strongly believe that the APR meaningfully involves us in the work because I have that personal experience. So what I wanted to do was just to think about also, well, why does the APR involve us community as members of the advisory committee? And here I just want to stop and share a couple of quotes because I reached out to people for seniors and I asked them, why does the APR involve us women living with HIV? And the first quote is from Jessica Albano, who is the vice president of the epidemiology and analytics. And the second quote is from Hunter Allen, who's a project manager, real world and late phase, both who work at Syneos Health. And I hope I pronounced that right. So Jessica says, the advisory committee is a vital component of APR's organizational structure and provides scientific oversight for the study. It was wisely assembled to include experts from a variety of backgrounds, including researchers and physicians from academic, government, public health, and clinical practice. We've been intentional about including community members to help ensure information about the registry is disseminated in an accessible way and to maintain a personal connection with those who are impacted by HIV and pregnancy. And Hunter tells us that the role of the advisory committee, which is made up of volunteer physicians and researchers, is to review pseudonymized patient data summaries provided by Syneos team in order to agree on study outcomes, aid in interpreting results, increase awareness of the study, and support results dissemination. The advisors meet independently as well as with the APR sponsor companies as part of the steering committee along with senior study team members. And so in terms of the recruitment process, steering committee expressed desire to expand the community representation on the advisory committee, and suggestions were solicited based on folks' active work and engagement in HIV and women-focused forums. Nominees were contacted regarding their potential interest. Virtual discussion was held with the Registry Coordinating Center and Study PI. Mutual affirmations of interest were recommended to the steering committee for review and approval, and onboarding was initiated. So it's also responsible for participating. We're also responsible for participating in semi-annual data and interim report review activities and attending steering committee meetings. And we also have the opportunity to join special analysis and publications working groups, suggest awareness activities, and or promote the registry. And so as a patient advocate and community member, I am part of the advisory committee. And what we also do is to bring the perspectives from the global patient community to the study. We weigh in on lay language and terminology used in results reporting, and also provide insight on dissemination of project information. Last but by no means least, my experience of being a member of the advisory committee so far has been very positive. Firstly, I feel included during meetings, my views are taken on, my input is valued, and my questions and queries are clearly responded to. Secondly, my medical vocabulary has increased in leaps and bounds. I read papers with the dictionary next to me. And finally, I really hope that the APR continues to meaningfully involve us and to truly ensure that we remain at the heart of all that you and we do together. Thank you.
Thank you very much. It was great. You also left out one big part. You fly all the way from the UK for our meeting. That's very, very, most people do Zoom when they live right around the corner. So you fly all the way from the UK, you and Claire. I have to give you that credit. So, all right. I do think
Thank you for having us.
this is me, and I apologize. I got on a roll and didn't want to stop. So now we're just going to briefly look at the APR results. So this is, and again, as Angelina just mentioned, we meet twice a year, one in person and one totally virtual. And so we just had our meeting, I guess it's been 2 months now. So this is data looking from, the inception of the APR from 1989 when it was just the Dean Registry through July 31st of 2024. You can see the number of pregnancies enrolled, the outcomes that were pending, because not all the reports come in. There were definitely reports that were lost to follow-up. And then you can see how many evaluable pregnancies that were going to be included in this analysis. Here's the demographics in the countries that have reported one or more cases. And again, 75 reports from countries that contribute greater than or equal to 0.1%. You can see here, I think the take home is the majority of the reports from United States and territories, but really they come from all over. UK contributes about 5%. You could just sort of run down and see, but majority of reporting is from the US. When looking at the CD4 cells, really it's a breakdown. There's about 34% have more than 500. You can see 200 to 400. And then there are still 12% that present with late. And this is the earliest CD4 reported. So that, and I see this in clinical practice. People still present with very low CD4 cells and even in pregnancy. And then the majority were asymptomatic and acute primary HIV or progressive persistent generalized lymphadenopathy. What was the earliest trimester of exposure? And again, this is important, right? Because when we went through that timeline, you can see the majority were first trimester exposures. And I think at some point you'll hear us differentiate, first trimester is the whole first trimester, but sometimes we're looking to see, did this happen prior to conception? And so it gets a little muddy, the waters, but here's first trimester majority. And then again, you can see second followed, then still small percent. Again, these are people that maybe present later, start meds late, are in the third trimester. The majority are live births, but again, you see really still spontaneous abortions, stillbirths, and then induced abortions in a small percentage. And then here's from the prospective registry, cases with follow-up data and that were closed through July 31st. So what you can see overall so this is all overall, by trimester, all of them. The proportion was 2.9%, and then you see here the confidence interval. When you look at first trimester, 2.9, very similar, and then second and third, 2.8 with the confidence intervals. So the relative risk when you look at first versus second over third, second and third, I'm sorry, is 1.04, and you see that confidence interval here has 1. So, really reassuring data. This gets a little confusing for people when you look at it, but I always love this forest plot. I wait for them to update this every 6 months. And if I haven't said this, all this is included when I go back and show you the website that you can pull all these interim reports up. All this data is available. Some people like looking at it this way. Some people like looking in tables. What this does in the forest plot is it lists all the drugs. So you see them on the y-axis, and then the defects over live bursts, it gives you the prevalence, and then the lower and upper bound of the 95% confidence interval. And again, like I say, this is updated. And then what you see is what's the involvement with the 2 different population comparators. And I just, again, I could spend a lot of time on this. I think the few takeaway points are, if you look here at the denominator, you can see the numbers, right? So obviously, Davidine's been around for a long time. You can see there's over 4,000 exposures. But you notice here, nothing is under 200. And why? It's because that's that magic number we talked about early on. To be included in this analysis, you need 200 exposures. That's to be able to do that detection, just like you would with sample sizes and when you do power calculations. When you go down and look at first trimester, you go across, you can see the prevalence and then the interval. And just to cut to the chase, when you go down here, there was really no increase across the board seen for any, which is just what I mentioned there. There is one that stands out. So there was a modest but statistically significant, that word always twists me up, increase in the prevalence of defects among first trimester exposure for 2 drugs. And if you look here, there should be an arrow. So it's nelfinavir, and it's for the metropolitan Atlanta, not the Texas Birth Defect Registry. And then the other one is didanosine, which is probably looking right at, here it is, didanosine. So you can see here. But the good news is, one of the things we do when we, come together at the meetings is we look, and people are not using this drug much. So we're not getting new reports. So even though it stands out as being statistically significant, we're not seeing reports coming from those 2 drugs, because hopefully many people are not using those drugs anymore. This is an executive summary. I won't read this to you, but I think I'll read the bottom piece. So the Antiretroviral Pregnancy Registry finds no significant increase in frequency of birth defects with exposure to antiretrovirals, and no pattern to suggest a common cause. Potential limitations of the registry should be recognized. Providers are strongly encouraged to report eligible people to the website listed there, or the website that's listed there. So there's an email and a website. And again, this is the website, and I'll show you a little bit later if you want to go where you can actually pull up the report. And if you want to learn how to report, there's a section in there for you. I will make one final comment. This registry could be much better if we had many more people reporting, right? We do have great number of reports, but the more we report, the quicker we can get access to the data. And now I know I have to turn it over to Lynn, and I'll be quiet, Lynn. Oh, you take it away.
So I want to bring home to you why this information is important. So I'm going to talk about efavirenz and dolutegravir. Next, Bill. So let's start with efavirenz. Next, please. So efavirenz is a problem or not? Next. So there were monkey data early on suggesting the potential for central nervous defects with in utero exposure, and 3 of 20 infant monkeys had CNS defects with in utero efavirenz exposure at levels similar to that with human dosing. So that was monkey data that were concerning. Next, please. Then there were a number of retrospective case reports of neural tube defects in infants born to mothers receiving efavirenz at the time of conception that raised significant concerns about the use in the first trimester. Next, please. However, as we talked about, you need a large number of exposures before you can determine whether there's really a significant increase in a relatively rare birth defect. And neural tube defect incidence generally is 0.1%. Next, please. So there was a critical need for unbiased data to determine if a risk for efavirenz, which was a very attractive regimen when given with tenofovir and FTC, could be given as a pill once daily. Next, please. So the APR was the largest contributor to a meta-analysis determining that first trimester efavirenz use was not associated with an increase in central nervous system defects. And this meta-analysis had birth outcomes in over 2,000 live births, found an incidence of neural tube defects of 0.05%, similar to the general population, and concluded that there was no evidence of an increased risk overall or CNS congenital anomalies with first trimester exposure. Next, please. This then enabled the U.S. Public Health Service perinatal panel in 2016 to change their recommendation from don't use efavirenz in women of reproductive age to say that the use of efavirenz is permissible during pregnancy regardless of trimester. Next, please. So let's talk about dolutegravir. Next, please. So the Botswana Tsisambo study was designed to evaluate the risk of neural tube defects with preconception efavirenz. So this study was originally started to assess the issue of efavirenz. And it's a prospective birth outcome surveillance for major surface birth defects, now covering 70% of all the births in the country. A trained hospital midwife does a surface exam, a research assistant consents the mother for a photo if there's a defect, and then there is a blinded review by a medical geneticist. In 2016 in Botswana, national guidelines changed to dolutegravir from efavirenz for first-line treatment, allowing comparison between regimens. And it has a good denominator with control groups and the ability to distinguish between regimens. It has an HIV uninfected group and HIV infected starting preconception or starting during pregnancy. Next, please. So I'm going to talk about the evolution of neural tube defect prevalence with preconception dolutegravir. Next, please. So in May 2018, an early look was done. There were 4 neural tube defects in 426 exposures, giving a prevalence of 0.94%. And you can see that that was significantly greater than with non-dolutegravir preconception, 0.12, efavirenz preconception, 0.05, and HIV uninfected individuals, 0.09. Next, please. And I just want to point out that they showed definitively that efavirenz was not associated with neural tube defects with this number. And this led to a wide recommendation that women of reproductive age should reconsider using dolutegravir and led to a lot of hesitation. Next, please. So in March 2019, now they moved from 426 exposures to 1,685 exposures, and you can see that the prevalence has now decreased to 0.3%. So there is still a significant difference between the comparison groups, but this difference is less than before. Next, please. And now you see the power of increased numbers. We now move to 2020, where we have over 3,500 exposures. The prevalence is now 0.19%. So down again, getting close to the others. Next, please. And this gives you the whole picture from March 2018 through March 2022. And it gives you some idea of the power of numbers to help you determine whether an association is real or not. With 494 exposures, you can see very alarming data. But by the time we've got to near 10,000 exposures, you can see that the rate of neural tube defects with dolutegravir is no different than any of the other comparison groups. And the other comment is all of these other comparison groups you see back in March 2018 had very large numbers. So their numbers are stable over time because they started with over 2,000 exposures. Next, please. And this just shows you the prevalence difference between the different exposure categories and basically the prevalence of NTD in infants born to women on dolutegravir conception has declined, does not substantially differ anymore from other exposure groups. Next, please. So what do we see in the antiretroviral pregnancy registry? As current, we have 899 periconception exposures, one neural tube defect prevalence 0.11%, exactly the same as you're seeing now in the Tasambo study, and no neural tube defects with the other drugs. Please note that the number of periconception exposures is still pretty small for some of these drugs. Next, please. And then this is very important. So this shows you the FDA drug label for use of dolutegravir in 2022, where they talked about the risk of neural tube defects and that basically alternative treatments should be considered at the time of conception through the first trimester. So what does the APR data and data from studies do for us? Next, please. So the FDA label for dolutegravir in 2024 was revised, and it removed all of these risk concerns. It gives you the data from the APR and from the birth surveillance studies to show that there's now no longer a risk. Next, please. The EMA, the European group, also approved a label change in October 2024, and Canada is now looking at a label change. Next, please. I do want to note that despite the fact that we now have data definitively showing efavirenz is not associated with neural tube defects, the drug label for efavirenz still talks about embryo-fetal toxicity, and that's because the company has to apply to the FDA to ask for a change. And ViiV did for dolutegravir, and for efavirenz, it wasn't requested. Next, please. So what have we learned? With efavirenz, we had concerning animal data with a mixture of defects that led to a warning in use in pregnancy when it was originally approved by the FDA in 1998. We had 3 retrospective case reports, which increased concern further in 2005. And then we had 1 single case in the prospective registry, and the FDA classified efavirenz as positive fetal risk. So the collection of additional prospective outcomes over a very long time has now shown that there's not an increased risk in neural tube defects. The drug label still hasn't been updated by the manufacturer. And the main message here is that well-designed birth surveillance with larger numbers would have resolved this question for efavirenz much earlier. Next, please. With dolutegravir, animal data did not raise concerns, but a well-designed prospective study detected an initial potential signal of concern. However, with an increased sample size, the prevalence has diminished and is no longer statistically significantly different. So given the decreased prevalence of NTD and the large benefits of dolutegravir is now a preferred drug in pregnancy. So what this tells you is that when you have small numbers, you can get erroneous conclusions about the risks of a drug. You need large numbers. And it was only with collection of additional data through birth defect surveillance and the APR that we were able to definitively rule out this neural tube defect association, and the manufacturer was able to modify the drug labels to remove exclusion in pregnancy. Next, please. So new drugs such as long-acting cabotegravir and lenacapavir will now have widespread use in reproductive age women as PrEP in women without HIV and as components of treatment for those with HIV. And while we have some data in pregnancy, it is limited. Next, please. So we now have data on 288 pregnancies with CAB-LA PrEP exposure at conception, 212 who continued CAB during pregnancy, and data on 105 completed pregnancies, almost 200 when they all deliver, with lenacapavir exposure at conception. And that's because these 2 studies have agreed to allow women who become pregnant to remain on study drugs so that we can find out safety data. Next, please. So remember we talked about the overall prevalence of something 3% versus 0.1% and the numbers. So with 288 pregnancies with CAB-LA, we can definitively rule out a 1.5-fold increase in outcomes with a background rate of greater than 10%. So that's miscarriage, preterm delivery, low birth weight. And we can rule out a 2-fold increase in outcomes with a rate of 3% or more overall defects. But we do have insufficient data for outcomes less than 3%. And when we have the 200 from lenacapavir, once we have all pregnancy outcomes, it will be similar. Next, please. So this is just to show you it's critical to continue to collect data on safety and pregnancy of these and other new drugs as they become available. And then I think my last slide. And just to make a comment that there are added complexities of surveillance of these long-acting drugs in pregnancy. First, it requires collecting data on ARV PrEP exposure in women without HIV as opposed to those with HIV. But the Antiretroviral Pregnancy Registry already collects data on tenofovir FTC PrEP in HIV uninfected women. And we also collect data on tenofovir TDF and TAF use in hepatitis B mono-infected women. So that data is already accepted as part of the APR. Now, given the long cabotegravir tail for up to a year, as you can see with the 2 graphs in women, the median time from last cabotegravir injection to a level below lower level of quantification was 67 weeks. So that means a woman who stops CAB but gets pregnant in the first few months after she stops is still exposed at conception, which complicates collection of exposure data. And so we need to standardize how to evaluate regarding timing of exposure and outcome. And so we will still be collecting data even if a woman stopped CAB and becomes pregnant in the next 12 months. We would still want to collect that data with particular attention to people who stopped CAB and become pregnant within 6 months. Next. And I think that's back to you, Bill.
All right, this will be the final section, and I'm going to run through this. I don't want to spend too much time, and then we'll open it up for questions. But I think an important question, and why do we do this webinar? One, it's to inform, and I think it's very informative to hear. I mean, especially the stories of what happened with efavirenz and dolutegravir, right? Because there was a lot that changed when you're managing individuals who are pregnant. So what can you do to start reporting? And I put this down because it's a common question I get asked. I can't do another thing. I'm very busy. I want to show you, and again, I've been doing it for years. So it's easy for me to say it isn't that hard. I do have, and hopefully we'll have data soon. I have an ongoing study that is looking at this, and we have providers who have not reported, and they are now reporting. Obviously, there's an economic incentive part of it. But one of the questions I went back and asked, and I'm interested to see the data, is, all right, now that you've been reporting and you're getting compensated for it, if the compensation goes away, which it obviously will at the end of the study, will you still report? So that data we should have shortly. And I think that's really critical, because I think one of the misconceptions is this is an impossible feat to do. I just want to walk you through the website briefly. So when you put in that apregistry.com, there's 2 different sites. There's one site for patients and one site for healthcare providers. And you can actually go in. And it just reminded me, and I thought it was important to bring up, and Angela, I don't know if you have a word. So Angela, all of us in the APR, one of our big things is awareness. How can we get awareness out? How can we get people who don't report to report? And at our last face-to-face meeting, Angela said, I have someone who has a lot of exposures. Can we meet? And so we actually met, I think it was this week or last. We had last week, I'm sorry, whatever. We had a good meeting, and I realized as much data is out there, as many webinars as we do, people really don't understand the APR. So it's really helpful me to hear what people think or, know about it. And so I thought that meeting was very, very informative. And again, I think what I got out of that was, this is going to be a lot of work. And I really try to say it's really not that much work. So if you go in, I'm just showing you different pieces. So, this was a question I got asked by Angela's colleague, how do you track these numbers? So here's what comes up. You have a patient log. You put the number down there. Now, a lot of these are on secured servers. I don't use the patient name. I use a combination of numbers that only I know how to do, but they're on a secure server. I put the chart number, what the EDD is, and then when I submitted the form, because that's important to know. The APR will also let you know. I just put a few screenshots. Again, I don't want to walk you through this. But I want to show you the amount of information that you collect. Like I say, it's not a lot. And Angela and I actually showed the person. Angela was very helpful pulling up the forms and saying, this is really all you need, right? So you're looking at, is the patient enrolled in a clinical study of something like an impact trial? Yes, no. Last menstrual period, date of conception, race. Was a dating ultrasound performed? If yes, and what is the corrected EDD? And here are some of the other things that are very straightforward. Was there a test to look for structural defects or genetic abnormalities? Ultrasounds. Did you do a cell-free DNA? Yes, no. And then, as Lynn mentioned, and I think that's really important, the registry is not just for persons with HIV, right? We do look at people without HIV if they're on PEP or PrEP. So if someone comes in and they're getting cabotegravir for pre-exposure prophylaxis, we want that, right? That's really important. If someone was pregnant and they got whatever happened to them, we have a lot of healthcare exposures. When I hear that, I go ahead and report it. So they don't have HIV. We're using them on PEP, but they're taking antiretroviral. So this is an antiretroviral. It's not specific to HIV. Obviously, HIV is a big piece of it. And then also hepatitis B. You look at the earliest CD4 classification and do they have hepatitis? And then obviously the medications, when you started and stopped. And that's, really, you may not think it's important, but I think Angela's description of how she looks at associations is really important. Was this a periconception exposure? Was this third trimester? That's really all helpful. And, how was it given? So this is really not a lot of work. This is your registration form. And then again, I just pull some things up here. This is the outcome. Was there a birth defect? Male, female, length, head circumference, birth weight, gestational age, and if there's a birth defect, you list things here. Now, and that's it, believe it or not, for the outcome. If you get a birth defect, then you will get a follow-up paperwork, right? Because if you notice here, we didn't collect smoking, we didn't collect, does the person have a history of preterm birth? Do they have a history of this? Do they have a history of that? We don't collect, that's not all collected. It's only after you submit a birth defect will you get follow-up. And even with that follow-up, it's still not a large amount of paperwork. And then here, if you have fetal losses, stillbirth, spontaneous or induced abortion, you can list factors associated there. And that is, I'm just going to stop and see if the both Angelas or Lynn have any comment to say about what's collected. And I'm not minimizing it. Yes, it is something else to do, but if you're following the patient, it's really not that much work. I mean, I always say I can submit a report in 5 minutes. I know where to go in the chart to get this information. And, just think about the prevalence of birth defects. It's not like every patient you see is going to have a birth defect. I went for years and I thought I'm doing something wrong. And then I finally got my first 2 defects and I'm like, uh-oh. But, you're not going to see it every time you do a report. Does anybody want to add any comment? I know I beat it to death, but
No, just I think that to emphasize to people that this reporting has real consequences for women living with HIV. It provides real information that's important. And that dolutegravir label change is one really good example of the critical importance of this information so that women can take advantage of getting the same potent drugs that men have been able to get. So it is really an important thing to do from a public health point of view. Thanks, Bill.
thank you. All right, so I think closing remarks and then we'll take questions. So obviously the success of the registry depends upon broad participation of healthcare providers. And I'm going to say it again for those who may have registered late. There is a misconception that only physicians can report to the APR. That is not true. broad participation of healthcare providers. It is not only physicians. So we want to get rid of that myth. Who register patients, provide follow-up information, and that data gets included in the analysis. I think one of the things I always look at is when we have, a significant number of lost to follow-up cases. I feel like that's lost data that really, when I look at the numbers, it makes me, upset because I just want to move that needle. I don't want to wait 6 years till we have safety data. That's a very long time and a lot of exposures and a lot of anxiety. Unbiased prospective reports, complete ascertainment of data on pregnancy, prenatal events, prenatal ARV exposure, and then birth outcomes and defects. And again, last comment, just remember, this is not just individuals with HIV. It's any time an antiretroviral is used. So it's hepatitis B, it's pre-exposure prophylaxis, and post-exposure prophylaxis. And here's the contact information. So if you wanted to report, you can easily send an email. I can tell you, I reach out to them frequently when I need new log numbers. They're very, very, very responsive to you. There's telephone numbers there, but really the email is very, very, very responsive. And with that, it's a god-awful picture of all of us, but I feel like, does anyone have any questions? I don't see any in there.
Are people unmuted, or do they want to type a question in? That would be fine as well. Ashley, did you unmute everyone?
They are able to unmute and utilize the chat.
Okay.
While we're waiting, does anyone have any final words? Angelina, Angela, Lynn already said. I know we've said enough. We've gone over our hour.
No, nothing from me.
Okay. Looks like there's,
Well,
oh, here we go.
why isn't it mandatory for all physicians to report?
Oh, boy.
Yeah, well,
That's coming from,
nice. That would be nice. In today's environment, making something mandatory will not be viewed very receptively, I don't think. So it is a voluntary registry for physicians to report their patients. And I guess it's really politics that people don't like to be told they have to do something.
there's been lots of talk about this, and I have to say in disclosure, so the person who asked that question is the project manager for my APR reporting study. And she actually gets to interact with all the people who are now reporting, and we always say, like, look, they're killing it. They're sending us all these reports that would have never been reported. And I think they realize, like, wow, this was not that tedious as we originally once thought.
Yeah, we even had difficulty getting clinical trials to report to the APR. And in clinical trials, you're collecting huge amounts of detailed data. Is the registry made well known to practicing physicians? That's one of the reasons for this webinar, right?
Yeah.
It's also the registry is also mentioned prominently in the perinatal guidelines, the U.S. perinatal guidelines, in several places, recommending people report. And if you have any great ideas about other ways to advertise it, please let us know.
Exactly. And I will say, I mean, we try to hit, to me, this is always the question, when I was talking about pre-exposure prophylaxis or HIV testing, I always say the room's packed, but am I preaching to the people who do it all the time? How do I get to the people who don't do it? And that's where we scratch our head. And I mean this seriously. A big part of every meeting we have is awareness of the APR, and we brainstorm. The advisors, the sponsors, and we all get together and do it as well. And we have, other meetings where we talk about publication committee, how to get these, let's go to a PA conference, let's go to a nurse practitioner conference, let's go to, the public health conference. We've been at ID Week, we've been at CROI, we've been at the International Workshop on HIV and Women. I mean, it's really everywhere. But again, I think the question is, how do we get to the people who are not reporting and don't go to those conferences? And that's the harder question to me.
Yeah, there's a good question about a model. You know, do people assign people to do this on a regular basis? So maybe, Bill, you could talk about how you do it.
Yeah, so again, that person's Dr. Paz is one of the fellows I work with who will be leaving us next week to go to University of Miami. So I will talk to you, Asith, about how to do this. I think models. So I think everyone does it differently. You know, my model has been when I finished my fellowship, I joined the practice where this was a regular part of the perinatal clinic, right? I learned so much from that model. The first model was don't make the pregnant person come to you, go to them. And so I, from the beginning, 2003, when I finished fellowship, I have worked to make sure that I have a joint clinic in the OB practice. So the pregnant person does not have to travel. And it just is, it's become part of my regular routine. And I think Lynn mentioned that providers don't like to be told what to do. And if you don't do it, it's like, here's another thing I have to do. It's another tedious thing I have to do. So I think you just have to do it and see that it's not, and it's not financially hard. You know, I do, and I know everyone from the APR laughs at me. I do the papers and I fax them in because to me, it's so much easier to check the boxes and fill the information. I told you, I literally, well, most people on here from Penn know I'm in my office very early and I do that paperwork. I spend a morning, I do it. It's 5 minutes it takes me because I know the patients. It is not that much work to get in. And it's not like I do 5 reports a year. We have somewhere around 80 to 100 a year. So it's a fair number.
There's a question about duplicate reports, and I don't know whether Taylor or Jessica, are you still on? Can you answer that question about potential duplication?
If not, I know the answer because this
Oh,
has come up.
okay, you can
No,
answer it, Bill.
But if they're on, I would love to hear them because I know this has come up before. I know they're both on. I know,
Hey, this is Taylor. Yeah, we
Taylor.
definitely have a mechanism per protocol to do our best to identify duplicates. You know, that's assuming that the information is consistently reported across both reports. But we do have multiple scenarios. If this and this, then potentially a duplicate. But we need the multiple criteria to align in order to truly feel confident that it is a duplicate report. Sometimes we do see that when we have sponsors that are reporting as well. We'll have a clinical study that reported, and then they reported to the sponsor, and then the sponsor reports it back to us. So definitely scenario that we're familiar with, that we have mechanisms in place to try and avoid.
Okay.
And thank you for the pharmacists who's saying that they report. Thank you.
Yes. Yeah, and please pass the word around because that is such, I mean, I ask all the time about reporting and, you know, and I literally get told only physicians can report and I get very upset because it's so not true. Right, one last. All right. So I guess if there are no other questions, I want to personally thank everyone for taking time on a Friday to listen to us, and hopefully you gain something from it. Hopefully you will take this back. Hopefully you will ask someone to report, and we can, you know, gain new reporters who can help us contribute to this important work. I don't know if the other panelists want to say anything. No.
Yes, thank you.
Yep. And have a great weekend, everyone.
You too.
Bye.
Bye.
Thank you.
Thank you.
Bye-bye. Thank you.